Hi, everyone. Welcome and happy Pride. We're happy you are joining us and appreciate your patience as we got live tonight. We are very happy to welcome back Dr. Søren Estvold, UMHS alumni, to talk to us tonight about LGBTQ plus medicine. Dr. Estvold, welcome.
Hey, thank you. How are you?
I'm doing well. How are you?
Not too bad. Well, thanks for having me tonight. I'm going to give you guys this great lecture. It's about an hour long, and it's all about LGBTQ medicine, which is perfect because it is June and it is Pride Month. So I know you guys don't receive a lot of curriculum for LGBTQ medicine. I know that I didn't. And even now, a lot of med students don't as part of their curriculum. So this is going to be super helpful for you guys because you will see this patient population almost every day. And then it all depends on what field you go into. But this is a very passionate subject of mine, and I've given this lecture all over my campus. I'm here in Augusta, Georgia at Augusta University, and it's been very well received because a lot of the different specialties, they see these patients every day. So just a little bit about me before I jump in. I did graduate from UMHS in 2018. I started on the island in 2013, so I was there for about 2 years, and then of course Maine, and then my clinicals. So you guys are almost there. You're doing it, and it is possible. And then I'm finishing up my family medicine residency on Friday, actually, and then moving across the country over to California for my fellowship. So hang in there. It is a tough road, but you guys can do it. And then finding a passion like this is actually what helped residency be really a lot more bearable. So if you guys have any questions, raise your hand, shout them out, or text them in. I don't mind taking questions at all during the presentation. And then I know we'll do a little bit of a Q&A afterwards. So if you're more shy, just write it down. But yeah, let's jump into it, okay? So full spectrum medicine, what does this mean? And usually this is the part where I'll ask the audience, but it'll be kind of hard because I can't really see you guys. But full spectrum medicine, it means that your patient population is incredibly diverse. It's not just men and women. It's not just a man with hypertension. It's not just a woman with depression, etc. It's the person in front of you has a whole bunch of moving parts that make them them. And if those get out of whack, we have to start treating them. And as a family medicine physician, we treat the whole person. We don't just treat the part of them that's gone wrong. So we try and find the root cause of it and treat it. So, and that includes our LGBTQ population. And so that's what I like to think is the spectrum part of this population. So who recognizes this alphabet soup, right? It's a lot. So LGBTQQ2SIAAP+. I like to run through this because this is what freaks people out the most is they know 2 or 3 or 4 of these, but they don't know the whole thing. And I don't expect you to know all of these, but as someone who this is kind of my specialty, you do have to know these things. So I'm going to run it through with you guys. So the L stands for lesbian, okay? Not just a female in this population, but someone who identifies as a lesbian. G for gay, B for bisexual, T for transgender, Q for queer, and it's okay to say that because it is a reclaimed word. Other Q for questioning, so maybe you don't know where you are on the spectrum, but you know that you're not heterosexual, definitively. 2S, that's a very new concept. It stands for two-spirit. It's actually a Native American concept, and it's thousands of years old. We saw this concept in the Native Hawaiians, the indigenous people of the South Pacific, more Native communities like that, and then Western colonization happened, and it stamped out a lot of these populations. And we didn't see them for centuries. And now the 2S people are starting to make an appearance again. And I'll touch on those guys in a little bit. I for intersex, A for asexual, A also for ally, we threw you guys into this, and then P for pansexual, and plus. Plus is everything else. So I don't expect you to use all of this. I kind of do expect you to use LGBTQ or LGBTQ+. That's really savvy, and it looks really competent when you use that in your notation and talking with your patients, okay? And for those of you who are visual learners, I kind of spelled it out here so you can see a definition to go with each population here, okay? But these are all very valid and appreciated members of this spectrum, of this population. And there's more gender identities, and we'll get into those in just a little bit. So labels, we love to label our patients, right? This is an African-American female. This is a Latino male. This is a bisexual man, right? Labels. Oftentimes our labels are attributed to genders. So we think lesbian is a female person. That's not always the case. Gay is not always just a man. Not every man in this spectrum identifies as gay. Bisexual, we think as binary, male or female. And then transgender, we kind of think of male, female, and other. Now, all of these can get skewed. That's why I put queer in there as X, right? Queer can be anyone who they and how they identify. And that could be like non-binary, gender fluid, etc. And then the plus is just a really good catch-all because we're discovering new gender identities all the time. And I'll show you why. But first, I like to touch on these. So do you guys recognize these two people, or at least one of these people? And usually someone from the audience shouts out, yeah, we recognize the woman, right? So these are drag queens. That's RuPaul, the most famous drag queen in the world. And then on the male over there is Spiky Van Dyke, the most famous drag king in the world. And they are not gender identities. A drag king and a drag queen are for entertainment value. They're performance actors, etc. They're not a gender identity. So I had to stick this slide in there because a lot of the people I lecture to are older straight white males, and they see RuPaul and they think RuPaul's a transvestite, or they think, well, that's accurate. They think RuPaul is a transgender woman. That's not accurate at all. RuPaul does not identify as transgender. They see someone like Spiky Van Dyke and think that's a transgender male. And that's not the case. These people don't identify as transgender. They identify as drag kings and drag queens, which is for a performance or performance value. Definitions. So again, for those of you guys who like to read a good solid definition, I like to talk about cisgender and transgender. So cis comes from the Latin origin of same, like same-sided, kind of like what we learned in chemistry, right? So having the same gender identity as the biologic sex that you were born with. So male gender with male biologic sex organs, female gender with female biologic sex organs. And then trans, meaning opposite, is when we see a misalignment of those, or an opposite alignment. So trans masculine, so female to male transgender person, trans feminine, male to female transgender person. And if you can use trans masculine and trans feminine, that's really, really good in your notes, right? It's really kind of hip and savvy. And it describes the person that you're talking about. They're a trans masculine presenting person. They're a trans feminine presenting female. Versus saying, oh, it's a trans male, which is a little bit slangy. It's okay to use, but when you're writing like professional notes and stuff, it looks really good when you use trans masculine, trans feminine. Now, sometimes you see like assigned female sex at birth, like ASAMB or something. And that's clunky. I don't even remember it. And I've been doing this field for about 4 years now. So really pick what works for you. But trans masculine, trans feminine, I really like those. I use that in my notation all the time. So does anybody recognize this, the genderbread person? So this is a really great way to explain gender identity for those of you who are visual learners. So imagine that like your person, the genderbread or gingerbread person there in the background, has 4 kind of permutations that you can play with. One is the identity in their mind and how that identity changes and how they identify. So if they identify as male, female, or other. Now, attraction, who you're sexually attracted to, right? Male, female, other, etc. Sex, what biologic sex organs are on your body. And then expression is how you present yourself to the world, your clothing, your hair, tattoos, stuff like that. So now imagine if you mixed and matched any of those in any of those combinations and you get a million different ranges of how a person can present. That's why we see gender as a spectrum. That's why we see people as non-binary, gender fluid, transgender, heterosexual, sexual. We see a whole range of ways that you can present yourself to the world and identify sexually. And I think that's awesome. We're just now starting to put names to all of them. And that's where we get like intersex, aromantic, demi-romantic, stuff like that. So the Kinsey scale, has anyone heard of the Kinsey scale? Usually like 1 or 2 people have. Dr. Kinsey first started doing his research in like the 50s and 60s. And he was one of the first people, he was a pioneer who really looked at sexual orientation and quantified it. And he interviewed thousands and thousands of people. He would go to like small towns and cities and stuff, and he would interview like the husband, the wife, kids, the nanny, the help, because this was back then. Anyone he could get his hands on to do this research, and he would ask them all these sexual health questions. And he was one of the first people to ever do this. And he found out that sexuality was on a scale. Most people are not exclusively a Kinsey 0, which would be heterosexual. And some people are exclusively a Kinsey 6, which is homosexual, but he found the vast majority of people reside on this spectrum somewhere in between on the Kinsey scale, where they have some homosexual or some heterosexual tendencies. His second kind of landmark finding was that he identified the true bisexual, someone who identifies equally as heterosexual and homosexual. That would be a Kinsey 3. And that's really cool because no one had ever described this before. No one had described it in the scientific literature before. And so he's attributed to being a real big pioneer for the sexuality spectrum. So we've been talking about sexual identities. We've been talking about gender identities. It is Pride Month. We see pride flags everywhere, right? So let's talk about the flags, because this population really likes to make flags for everyone. So on the left, or at least on my screen, the two big ones, we see the top flag with the feathers on it. That represents the two-spirit people, okay? And that's a cool identity because those people aren't transgender. I want to make that really clear. A two-spirit person is not a transgender person. They believe that they have a male spirit and a female spirit that resides in one body. So they have two spirits living in one body. And that's really cool. That gives them feminine traits, that gives them male traits, and gives them a whole range of traits in between. They were often highly revered in their populations for this. Like the Hawaiians, they have a name for it. I can't remember what it is, but those people who identified as two-spirit, they were often seen as healers, as protectors of their society. They would help watch the kids and help educate the kids, stuff like that. They were very integral and respected parts of their society. And then Western European colonization happened and stamped that out, unfortunately. Now, the bottom flag, that black, white, and rainbowish one, what is that? Who's that for? So that's actually the ally flag. So those are our heterosexual friends who help support this community. We made you guys a flag as well. But then you can see a bunch on the little flags. We have like the bisexual flag, the demi-romantic flag, the aromantic flag, polysexual flag. Everyone gets a flag, right? Everyone likes to be represented. The bottom two rows, I kind of wanted to call attention to. Those are not gender identities. Those represent like the bear population, the leather population, the lesbian something population down there. Those are sexual kinks and fetishes. They're not gender identities. So it's important not to confuse those, because oftentimes those get weaponized when used in the wrong hands, if you know what I mean. So cool, flags. And because it's June, I like to include a little bit of flag history. The gay pride flag, the rainbow flag, wasn't just like a rainbow made into a flag. There's actually a lot of thought put behind it. It first debuted, I think, in 1972 in San Francisco. And it was hand sewn, and each band represented something. And so you see each color represented life, healing, sunlight, nature, serenity, which I thought was really cool. And then it wasn't until 2018 when we updated that flag and we added the gender minority colors of black and brown. And then we also added the transgender color. Now it gets a little bit muddled. There's another flag out with a yellow triangle with the purple circle in it for the intersex people. I think it's great to be inclusive, but we're starting to get a little bit, the aesthetic's starting to get a little bit blurred. So Pride Month, right? This is it. We have Augusta Pride coming up this weekend. Augusta University, my university, celebrated their Pride Week last week. So we see corporate pride is happening, right? Everyone turns corporate colors. I don't know if UMHS has done a rainbow logo yet, but I would love to see it, hint, hint. But we all recognize corporate logo changes, right? And then everything will snap back to reality on July 1st. And I like to highlight this because Pride celebration shouldn't be something that just happens only during June, right? We have LGBTQ people that exist all year round, and they have problems all year round. So it's important to be prideful all year round and really appreciate this population all year round and not just during June, okay? A couple key dates I like to throw in here. So Transgender Day of Remembrance coming up in November 20th. This is a special day. It's kind of a vigil day because it's to remember everyone who is a victim of violence against transgender people. So here in Augusta, 2 of my patients have actually been murdered who were transgender. So it's a very real thing. This population, the transgender patient population, is highly victimized and experiences a lot of violence over their lifetime. So this is a day to kind of remember those who have been lost to this, okay? And then National Honor Our LGBTQ Elders Day in May 16th, just happened in this past spring. So this is great because oftentimes in this population, if you age out over the age of 40, you're considered elderly, which is not the case at all. And then usually by the time you hit 60 or 65, you tend to cease to exist. The population doesn't really tend to acknowledge you. You see less people of this age participating in like Pride Festival or being out and about. And it's really sad. And this population, this like 65 and older population, feels really invisible. They feel really unwelcome. They feel really underrepresented. So it's important to remember that they are a vibrant part of this population, as we'll get to in the later part of my PowerPoint. But it's also important to remember this population and to really appreciate them. So we made a little holiday for them. I think it's really special. Take a drink. So let's get into the science behind this. So this is called the Gender Minority Stress Framework. This is something I really want you guys to pay attention to, because this is kind of the basis of all healthcare in this population. So if you're interested in doing LGBTQ medicine or transgender medicine, this will be a cornerstone of what you're treating and working with / against, okay? So if we start at the end of the screen where you see LGB hetero, so that's the patient right there, identifying as one of those categories. And you can see they experience minority stressors. That's kind of the first column of rectangles that you see there. Those minority stressors can be anything. They can be peer victimization. They can be microaggressions. They can be parental guilt, having angry parents or unaccepting parents, being rejected. So those small stressors that don't physically do anything, but mentally they are doing something. And those are compounded over weeks to months to years. And we start seeing psychological mediation factors. So now these people are having negative social outcomes. They're having lack of social support networks in their daily living. They're starting to use more substances, okay? And so these people, they're starting to compensate for these stresses that they're experiencing on a daily basis. And they're doing things like they're picking up drinking, smoking, alcohol, marijuana, harder drugs, stuff like that, cocaine, heroin, club drugs, et cetera, to escape or lessen the stresses on their life. And now we're compounding those over months to years to decades over a lifetime. And that's where you see the big green box, that lifetime cumulative stress. And that means that these people are starting to have real life health outcomes. So think about it. You're 18, your parents just kicked you out and you start drinking a little bit to take the edge off, right? And then pretty soon you're 32 and you've now upgraded to a fifth of alcohol a week. And then now you're 40 and you're doing a fifth of alcohol a day. And that's wounding up over your lifetime. Your cortisol levels have been through the roof for decades now. And we're starting to see we're starting to see liver disease. We're starting to see heart disease. We're starting to see lung disease if you're smoking over this period. And then that's when they wind up in my office or my ER or in my hospital with these real health outcomes that I now have to treat, all from the very beginning of when they're experiencing these microaggressions, which are happening on a daily basis. So I hope that makes sense. Just a little bit of a plug for myself. Me and the Georgia Cancer Center just came out with a publication that shows that being an LGBTQ person increases your risk for cancers. And that's lung cancers, liver cancer, heart disease, stuff like that. And so we just actually published that like 2 weeks ago. And it's directly linked to what's called the allosteric load, but these stressors that then affect like yourself on a cellular level and lead to disastrous outcomes and health outcomes. So we can touch on that more if you guys have questions. So now let's look at it, right? So if we think back to the very edge of that last diagram, the person, right? As a family medicine physician, we look at the person. We see a lot of these health disparities are linked to race. That's not entirely out of the box thinking, but we do see a lot of these disparities happening in the Black and brown populations. This Candler study that came out 3 years ago looked at Black men who have sex with men who were sex workers. That's the MSM-SW. At anyone who did sex work in the past year, which is a pretty significant number. And they found amazing things in this population. They found that almost half of them had HIV. They found that they're more likely to be of Hispanic heritage. They're likely to exhibit bisexual behavior. So they're having sexual encounters with both male and females. Had a reported income of less than 10,000. So very, very, very large poverty. They showed increased intimate partner violence. So whoever they were trying to be with was hurting them. They were victims of assault. They had polysubstance abuse. So that could be, like cigarettes and cocaine or cigarettes and GHB. They found depression in a majority of them, and then lots of STIs. So it's like, where do you look in this population when you want to do some good or help, or who do you treat? You start looking at the minorities, okay? So let's jump into it, okay? I like this quote here: LGBTQ people of color are more than twice as likely to avoid going to the doctor's office. Which actually, if I think about it now, in my practice at family medicine clinic, the majority of my transgender LGBTQ patients are white. But then at my free clinic, at the equality clinic, about half of them are Black, I would have to say. And those are just the ones who show up, right? So it's really important that we reach out to these populations and help get them to see a doctor, okay? So why are they not seeing a doctor? Because there is discrimination in healthcare. This was really something that's interesting that the WAY study found, was that over half of this patient population experienced some form of discrimination at the doctor's office. And if you're transgender, you are more likely, as in 70% more likely, to experience some form of discrimination just going to see your doctor. The Casey study found that people experience anything from slurs, microaggression, sexual harassment while at the doctor, violence while at the doctor's, bathroom harassment. This led to 18% of them avoiding healthcare altogether. They found that most of these were happening in ethnic and racial minorities. And then they showed that there was much poorer outcomes in the transgender population. And this rings true. So one of my friends who is, I think she's still a UMHS student, she was working with me on this project. And I actually had her go undercover to family medicine clinic to try and get established as a patient. And so she went there and she posed as a lesbian, and she brought her girlfriend with her, and she wanted to just make a simple appointment to be seen by me. And it flustered our front desk people so bad that, because she was identifying as a lesbian and she wanted to make sure that she could get comprehensive care, that they couldn't complete the paperwork with her. They couldn't, they were so confused and so not helpful that she ended up not getting scheduled for an appointment at all, and ended up leaving family medicine clinic not able to see me, which is terrible. And so since then, that shined a light on our front desk that said we need to do more inclusive training there so that this never happens. And so that's something that I've also been working on these past 3 years. And now our clinic is very friendly and they're very inclusive, and they've done an amazing job of stepping up to the plate. So the medicine, heart health. This is a really cool study that I want you guys to know about. The AHA, American Heart Association, did a study in 2020 where they only looked at this population, the LGBTQ population. And this was a landmark study for them because no heart study had ever looked exclusively at LGBT and Q patients before and come up with their outcomes. And they found some really interesting things, okay? So they found that women tend to have a larger BMI, and we'll jump into that. There was a much more pronounced tobacco use in this population. There was possible cardiometabolic risk from using HRT hormones. And then transgender patients were actually more likely to have diabetes. So what do you do with this information? So as a physician, I read this study and I think, all right, how do I change my practices? So at a quality clinic, we've started screening everyone for diabetes now. We do an A1C if you're over the age of 35, or if you have increased risk factors. For women, we do a lot more counseling on diet, exercise, okay? We screen everyone for tobacco use, and we set them up with the Georgia Tobacco Quit line, stuff like that, okay? And then we see this, that the study found that they have more psychosocial stressors, especially across their lifespan. So now every patient who comes to a quality clinic is also set up with behavioral health, who's there on site, and they do a little behavioral health consultation to see if they do need help or if they need counseling, et cetera. And oftentimes they do. Next slide. So let's jump into it. I kind of broke up this medicine part of the presentation by the different populations. So that's why it's women's health. It's not lesbian health. It's not queer women health. It's any woman identifying or biologic woman here. This is kind of how I go through and work them up and take care of them, okay? And that's Olympic star Megan Rapinoe, out lesbian, very proud of her. Olympian. So social determinants of health, right? What are they most at risk for? We see that these women are much less likely to seek healthcare, mostly because they receive inappropriate healthcare, such as not getting a pap, not getting a mammogram because of how they identify, which is inappropriate. They have breast tissue, they need a mammogram screening, okay? They have a cervix, they need a pap smear, regardless of who their sexual activity is with. So that's important. They're less likely to have healthcare. I like to bring this up early in the presentation and I poll the audience, like, how do you get healthcare? If you think about it, how do you get healthcare? So I had healthcare through my parents until I turned a certain age. I think it's 27 or something. And then I didn't have healthcare. And then I had healthcare through UMHS, which covered like nothing, but like was disaster care unless I needed to be airlifted off the island, which I never used. And then how else do you receive healthcare, right? You can marry into it. Maybe your spouse has a great job and you can get healthcare through them. But what if you can't get married, like a lot of this population? Then you don't have access to that. Or you can get healthcare through your job. But what if you are so discriminated against, you can't really hold down a job? It's hard for you to hold down a job, or you can't get a good enough job that actually has healthcare, right? You're gonna have to pay out of pocket. An American healthcare system, you're paying thousands of dollars every year, and that's not financially feasible, okay? But oftentimes these women tend to get healthcare at a much later age, and that's when they enter into the healthcare system. So then I'll see them at 40, 50, and 60 years old, and I'll have to kind of backtrack on problems that have been brewing up inside them because they missed annual checkup for the last 20 years, okay? So I want you to think about that. Health considerations. So then they're now sitting in front of me. So now what do I have to address, or things I have to screen them for? One, we saw that from the AHA study that this population tends to be overweight, right? They have an increased BMI greater than 25, which is not good because then that snowballs into a whole bunch of health effects, right? Increases your risk for diabetes, for heart disease, cardiovascular disease, COPD, sleep apnea, hypertension. All of those become compounded only because you're overweight. So if we can teach them at an earlier age to control their weight or keep their weight down, then they're at less risk for these health things that all require medication and studies and imaging and workups and expenses, et cetera, when we can focus on their weight, okay? The AHA study found that this population is 200% more likely to smoke tobacco. Like 200%, that's an insane amount of smoking, okay? So why are these women smoking so much? Mostly it's for stress relief, okay? That's why a lot of people smoke. Mostly it's social as well. Their friends are smoking, and vaping counts too as smoking. So when they're like, no, I don't smoke, I vape. Same thing, there's nicotine involved. There's even less filters involved, okay? So I screen everyone for tobacco, and if they're smoking, we work on cutting down, risk reduction, getting them set up with as much free stuff to help them quit. We even have a tobacco cessation clinic here at AU that I send everyone to. We found that populations increase risk for alcohol use, right? A lot more drinking, usually socially. Increased cancer risk due to prolonged estrogen exposure over your lifetime. So does this ring any bells for people? Do you guys kind of understand that? This is kind of an interesting concept. So I don't want to say heterosexual women. I want to say women who have children, right? When you get pregnant, your estrogen kind of drops off for 9 months. You deliver, your estrogen comes back up. Okay, you get pregnant again, it drops down again, and then comes back up. You get pregnant again, it drops down again, and then it comes back up. And so you're having these like gaps in your estrogen exposure over your lifetime. Well, imagine if you don't get pregnant. So you have high estrogen over your entire lifetime. That's a great recipe for getting cancer. So we need to screen these women for endometrial cancer, for ovarian cancer, et cetera, because they're at increased risks for it. And then we have to still ask these women about their fertility wishes. Do they want to have babies? Just because they're in a relationship with another woman doesn't mean that they're not considering having children. So then you need to talk about like freezing your eggs, et cetera. But you need to bring that up. All right, now the action. So now what am I going to do physically for them? What am I going to do? I'm going to start screening them with a lipid panel. Okay, make sure that they're not having heart disease. Make sure they don't need a statin. Screen them for diabetes, hypertension, all those basic things. Alcohol, tobacco counseling, give them their pap smears, their mammograms. Talk to them about birth control. Just because a woman identifies on this spectrum doesn't mean she's not having heterosexual relationships at all, ever, occasionally, whatever she wants. ask her that, okay? This is the time where you deep dive into that sexual history and figure out where you can help her. And if she needs birth control, what kind you can give her, okay? And then we screen everybody for mental health with a PHQ-9. That's super important. The PHQ-9 is a 9-point questionnaire to determine their depression rate, basically. And so everyone on this patient population spectrum is at increased risk for depression. So we screen everyone with a PHQ-9. Men's health. Again, gay men, men who have sex with men, queer men, any kind of male identifying person, this is where we're going to talk about them. So their social determinants of health. Again, less likely to have access to healthcare or seek healthcare, kind of like what we explained earlier. We see this really sad twin effect of racism and homophobia within the queer community itself, which is very unfortunate. And there's not a good reason for it, and there's not a good solution for it. But that's saying if you're like queer and Black, you're going to get discriminated by the queer other people in your community against you. And it's really unfortunate. And it's something that's been fought for a long time, and I wish it was not there. But it's something you have to consider. The Black population is disproportionately affected versus the white population with their health outcomes. We definitely saw that in the WAY study. No, not the WAY study. In the earlier study that we talked about with the health disparities, right? The Black and Latino populations are disproportionately affected. We saw that racial allocation of resources is also disproportionate as well. If you think back to like any propaganda about like the AIDS epidemic back in the 80s and 90s, who did you see on all the brochures and the posters and the commercials, right? If you just like search your mind for it, it was all attractive young white men, right? They were, the poster boys for all of that. They were the ones who received the majority of the medications and help resources, which is really unfortunate because then a lot of the Black, Latino, other population, they died out because of it. So that's changed. And we can see that. We can see that in the Biktarvy commercials that are on TV right now. If you see a Biktarvy commercial, everyone's in the Biktarvy commercial. You can be transgender and taking Biktarvy. You can be Black and on Biktarvy, Latino, female, male, everyone is well represented because they did a good job of avoiding this racial disproportionate disparities. So I think that's really important to point out. This male population is more likely to be single, okay? They're more likely to be estranged from their family. I want you to read that as kicked out from your family. But the cool thing is they're more likely to create their own chosen family. So their own social circle of close people, friends that they're very close with who take care of each other. These little like family units, if you will. And that's a very special thing. So always ask people what their social support network looks like. So their health considerations, they're only 50% more likely to use tobacco versus 200%. They're much more likely to abuse alcohol though, and they're more likely to abuse substances. And I want you to read substances as club drugs. So that's like GHB, methamphetamine, Molly, Tina, etc. Ask them about it, right? Ask them what they're taking and where they got it from, and if they're taking it safely, and if there's any way you can do risk reduction for it. I actually just gave a lecture to the local kink community here in Augusta, and I went out to the bar at like 9 o'clock at night, and we had this whole kind of hour-long lecture where we talked all about chemsex, and that's where you have sexual encounters while you're high on some sort of chemical substance, which can include alcohol, can include innocuous things as like Viagra, but also like GHB and GLB and methamphetamine and stuff like that, and why those are not good things to do. And people were very receptive to that talk. So it's a thing to talk about. Much larger risk for depression and suicide, especially in the young male queer community. So that youth population, that like 16 to 24-year-old population, committing suicide, really sad. So we have to reach out to them. Much larger risk for STIs. A lot of them think that they're invincible and an STI can be cured with medication. And we see a higher incidence of HIV as well, despite the education. And that's interesting as well. We're seeing that HIV incidence because the younger population did not see the horrors and the ravages of the AIDS epidemic from the 80s and 90s. So they don't have the fear associated with it, whereas queer men in their 50s, 60s, and 70s lived and survived through that. So they're very, very aware of using condoms and protecting their sexual health because they saw how devastating it was. And even though if you contract HIV, you're no longer dying usually from HIV AIDS anymore. Usually you have a normal or semi-reduced lifespan. and you can live a very functionally normal life. So they're just not as afraid of it as much. We also see a risk for anal cancer due to anal receptive sex. And then we see eating disorders and body dysmorphia in this group. So we have to ask them about it. Again, PHQ-9 limb. Here's my little plug for PrEP. I hope you guys know all about PrEP. PrEP is a wonderful drug. It stands for pre-exposure prophylaxis. It's for HIV only. That's why we say it's PrEP plus condoms. And that's super important because it's a once daily pill that can protect you from HIV. Why wouldn't you want it if you're at increased risk for contracting HIV? Now, the CDC tells us that you have high risk sexual exposure if you have greater than 4 sexual partners in your lifetime. Oftentimes, that's a weekend for this patient population. So ask them about their exposures and their risk factors and get them on PrEP and give it out like candy. Here's how to run through it, how you do your STI screening and your HIV screening, what you test them for, and then you bring them back every 3 to 6 months and redo testing and keep them on it. There's 2 main kinds of PrEP. There's Truvada, which came out like 10 years ago, and Descovy, which came out about 5 years ago. Descovy was tested in transgender patients. So, it's the newer one. People really like it, but it makes you gain a little bit of weight. Whereas Truvada is like the tried and true one. It has great testing outcomes. Now, the cool thing is Apretude just came out. Apretude is the long-acting injectable PrEP. So you take it and you're good for 8 weeks. And then you go back to your doctor's office and you do all your testing and you get another injection. So versus a once daily pill, it's a once injection every 8 weeks. So if you're terrible at taking pills and you can't remember to take your PrEP, go ahead and you get on Apretude. So, and PrEP is pretty much free. Out of pocket, it's like $1,400. But Gilead, the maker of it, has a patient assistance program that just about everybody qualifies for. So your patient should never have to pay for PrEP. So at a quality clinic, we get people on it as quickly as possible. So the bisexuals, let's talk about them. They're important because they are the largest patient population in this spectrum. Okay, there's over 15 million bisexual people out there. Takes up 40% of this patient population. And oftentimes people were just dismissed as bisexual. It was just a phase. It was not a real thing. It was just the stop on the way to being gay, etc. And that's not true. Being a bisexual person is a very valid experience. So it's a very truthful experience. So what do we consider with them? Still do all of your regular USPSTF screenings. So that's a guideline that came out that tells you like when to screen for tobacco and when to screen for HIV and when to screen for diabetes, stuff like that. So when to do your pap smears, et cetera. So you still follow those guidelines. They're at the greatest risk for depression and suicide out of everyone in this patient population. So we PHQ-9 them every single time. Ask them if they want to be on PrEP, if they have multiple sexual partners or experiences. That's super important. But yeah, very big part of this patient population. So transgender health, let's get into it. Do you guys recognize any of these people? Most people will recognize the woman over there, okay? That is Laverne Cox, one of the most famous transgender females ever to exist. She was from Orange is the New Black. She's now super famous. And then that's, I think, Ashley Laith, a UK model. These 2 people are 2 very good examples of a transition and as a transgender patient. And I like to point out that a lot of your patients do not look like this, okay? Oftentimes you'll see them somewhere along their transition journey, whether they're at the beginning or at the end or somewhere in between. And so always be on the lookout, but I don't know where I'm going with this, but yeah, so that's them. So the number one thing that I always get asked about and why I get asked to give this presentation is everyone's like, oh, I get tripped up on pronouns. And so I need more training because I'm just confused about this. And that's weird to me. We learned how to use pronouns in like 1st grade, right? And then we've been using pronouns ever since. It's really not hard. I think you're just being lazy. So what do? You ask people what pronouns they prefer. Breaks the ice. It shows that you're a little bit savvy in the LGBTQ spectrum, right? And you're taking an interest in them. And they'll say, oh, I prefer he and him, or she and her, or they and them. And then that's what you use in all of your documentation and when you refer to them. When in doubt, use they, them. When in doubt, use all. Y'all means all. That's kind of a joke down here in the South, right? But y'all is still gender neutral, so you can still use it. So when in doubt, just ask. And people really like that. That's Christine Jorgensen. She's who the movie The Danish Girl was based off of. She's one of the first post-op gender reassignment surgery patients from, I think, the 50s. And it made her kind of a celebrity from going through it. And she really like hammed it up. So great movie to watch if you want to learn a little bit of history there. But the transgender population, so what are their social determinants, right? Violence. We definitely talked about violence. Violence in the home, violence in the community. I always ask my patients if they feel safe at home and they feel safe where they live. I think that's super important. They're more likely to be murdered, especially if they're a person of color, which is really scary. So if you're Black and transgender, you're much more likely to be killed. So I always ask about safety and what their safety plans are, okay? Much more likely to contract HIV. That's usually a statistical problem because this patient population is so small and there tends to be a lot of sex work that it's just much easier for the rate of transmission of HIV to be higher within this population. And then they're also seeking healthcare less, which means they're getting screened for HIV less, which means they're having undiagnosed HIV and don't know their status much more rampantly, okay? Very, very unlikely to have health insurance. That's why at a quality clinic, which is my hormone replacement clinic, 99% of our patients are transgender. And then occasionally we'll do like just regular preventive care for a lesbian patient or a gay man, et cetera. Much more likely to be socially isolated and very, very big risk for depression. So we're PHQ-9ing them. We're setting them up with counselors, giving them behavioral health at every possible chance. Again, the depression is really bad compared to the regular population out there, okay? It's incredibly, incredibly high. So we always have to screen for it. That's Miss Universe Spain, the first transgender beauty pageant contestant. And then down there in the smaller box, that's actually Miss Nevada from a couple years ago, who's the first US transgender beauty pageant queen. So what are we doing medically for them? So besides the HRT, which I'll hop into, we're still screening them for appropriate biologic sex organs. So if there's a cervix on your trans-masculine man, then we're going to screen it if they're of the age that they need a pap smear, okay? If there's breast tissue, we need to do a mammogram for that. We still need to screen for like lipids. We still need to ask about depression, safety, give them PrEP if they're a good PrEP candidate, et cetera. So all of the normal things, like there's nothing new or scary about it. So the transgender medicine. So this is what I do. Transgender medicine is about half of my patient population, which I love. I work a lot at a quality clinic, which I'll tell you guys about that in a little bit. That's all HRT. And then in my family medicine clinic, I'm seeing transgender patients, several patients a day. I have a very large patient population for it. And I love it. It's very easy to do. So I'm going to walk you guys through it so that if you have a transgender patient, like you can at least be a little bit savvy about it. So for the trans-masculine patient, that's a female to male transition. All we're doing is we're giving them testosterone and we're giving them at little bit amounts, nothing near what you give a bodybuilder, just like little bits. And a transition is going to take 4 years. It's a second puberty that you're pushing them through, okay? In their first year, they're coming to you every 3 months to check their levels. We're looking at liver levels to make sure our liver enzymes aren't crazy, looking at kidney function, looking at their hematocrit, making sure that they're okay. And then we're tracking their hormone levels to make sure the hormone levels are transitioning appropriately. And then your trans-masculine men, you're giving them pap smears as like regularly advised. It's not uncommon for me to get like a 28-year-old trans-masculine man who's never had a pap smear before. And they will fight you tooth and nail about it, but I give them 3 options. I'll either do the pap, I'll teach them how to do a self-pap at a quality clinic, or I'll set them up with a really friendly OBGYN. But usually I will give them 6 months to get it done so they don't squirrel their way out of it. Because of course, that's how we get cervical cancer and that's how people die from it. And it's completely preventable. Transfeminine, very easy. So that's your male to female transition. We're starting them on estrogen, very low doses of oral estrogen. 2 milligrams is usually your starter dose for your first year. And then spironolactone, about 100 milligrams is kind of your starter dose. You do have to tell them that they will pee a lot because spironolactone, right, is a diuretic, usually used for blood pressure. Again, we're checking labs. We're checking estrogen level, testosterone level. We're checking liver and kidney function, et cetera. We're making sure that if you're on estrogen, you're not smoking because that's a huge clot risk. And that's actually a contraindication for me to starting therapy. So if they're smoking, I'll give them a month to get the nicotine out of their system before I start them. And if they start smoking while on HRT, I will stop their HRT. That's how serious it is. I've only had 2 patients throw clots before. And mostly one, it was due to her AFib that she already had pre-existing. And the other one, because she wound up in the ICU from a suicide attempt and was intubated and flat and not moving for 7 days while on HRT. And that will cause you to clot. So we're getting through it. So the silver population, so anyone 65 and older. Remember how I told you this was the population that tends to be forgotten about? So we want to talk about it because it's still a very valid part of the population. There's still over 1 million LGBTQ elders who are over 65. And they have large disparities. So they're very, very likely to be single at this age, which is really sad because no one's there to take care of them, right? They don't have family members. They don't have children who are going to help take care of them as they age. Like imagine your parents and they didn't have anyone to take care of them. It's really sad. They're, like we said, less likely to have kids to support them, more likely to be in poverty, okay? Not able to take care of themselves as they age, very likely to live alone, which puts them at fall risks, which is very sad because a fall almost equals death for a lot of people. And then very unlikely to disclose their orientation to their healthcare provider. I mean, that kind of makes sense, right? You're 65, you've gone your entire life feeling uncomfortable and you're not going to disclose your orientation. It's not like you're going to turn 66 and come visit Dr. Estvold and be like, well, they would probably disclose to me because I tend to be very friendly. But you get my point, right? If they see like their nephrologist, they're more likely not going to say anything. So it's important to create a nice, safe, and supportive environment for them. And they're sexually active. I love this slide. So 92% of people over the age of 65 do not use condoms. What? That's still important, right? You're still at an HPV risk. You're still at risk for STIs, for HIV transmission. Like we need to talk to our elders about using condoms and do all the fun demonstrations, etc. So 53% of them are still sexually active. And then even in the 76 to 85-year-old population, 26 of them, a quarter of them are still sexually active. I think that's incredible. More power to them, okay? But teach them about safe sex and STIs, etc. Okay? It's a fun conversation to have. So this population still needs care, right? So they're dying of normal things like heart disease, okay, and old age, brittle bones, etc. We still want to do all of our mental health screenings, screen them for substance abuse, screen them for depression, and then all of your regular screenings, your cancer screenings, your heart risk screenings, your diabetes screenings, etc. All those normal aging things, we're going to put them through. So that's the majority of it. What are we doing at AU, where I'm from? We have a couple things that I started initiating. And this is not like a toot my own horn section, but this is like things that you guys can do to help kind of create a more inclusive environment. So I created a poster my intern year that broke things down by population and put all those little factoids that I was telling you guys about, like lesbians being more overweight and 200% more likely to smoke, offer people PrEP, etc. How to do PrEP screening, screen everyone for depression, stuff like that. So basically, if like you had a bisexual patient in front of you, and I don't want you to panic, but if you were to just select one thing off of that thing and be like, oh, they're at risk for depression, let's PHQ-9, perfect. You did a great thing for them. And so I ended up submitting this poster and it got published a couple times. And it's actually up all over Augusta University, which is kind of fun to encounter. And then we made badges. I don't know if you guys can see them, but we have badges here, these rainbow badges. And it's basically the poster condensed into a badge form for 2 reasons. One, it was given out to anyone who is patient facing. And so, especially if you're a provider and you're like, oh my gosh, I have a transgender person in front of me and I don't want to panic because Dr. Soren said to screen them for HIV and a PHQ-9 and offer them PrEP and pull these labs. Awesome. You did some great work. And now by the time the patient gets to see me, hopefully you've done something really great. Or, you know, you look at your badge and you go, wow, I have a PrEP person on PrEP here. So I need to get a CBC and a CMP on them and do their STI screening. Perfect. You did some great medicine right there. You're keeping them safe and healthy. The other really great thing about this is the badge, the rainbow kind of peeks out because it's off center from my other badges. And I designed that intentionally so that you see it. This population is very attuned to seeing anything rainbow colored. And they'll see that and they'll think, oh my gosh, like this person's a safe space for me to talk to come out to. And you'll get totally different histories from someone who is open and sees that you're welcoming to this community versus the older white male doc that they just said they were here for abdominal pain, right? So very, very helpful. We printed up thousands of these. They're now all over the hospital. And then I think I've actually sent some out to you guys, but if you contact the woman in the email down there, she has like hundreds of them and can probably send a bunch down to the island or Maine or wherever. So very, very cool. It's a great tool to use. Equality clinic where I work. So I'm actually coming up on my last equality clinic next week. I've been working there for 4 years. I started working there because I didn't actually match my first round for residency. And so I knew I needed a volunteer position. So I started volunteering here. And also the program director for family medicine was the main director for this. So it put me in front of him twice a month. And we see patients all the time. So now I'm one of the main providers for it, which is really cool. I see about 20 patients a night. We do it 2 nights a month. And we've been doing it since, I think the clinic's like 10 years old now. We were open through the entirety of COVID. We went virtual and we did it all virtually on our computers and iPads and stuff, which was very cool. And we continue to provide HRT for them. So the hormone therapy for them. And then every once in a while I'll come in for a person, or I'll have a person come in who's just a straight up, like a primary care visit and they haven't seen a doctor in like 3 years. So, and you can do that. Other resources for you guys, Glamma is a great website. So you can plug in like your zip code and help patients find providers that are near them that are very friendly. So I'm on there as well, which I think is really cool. The Trevor Project is geared more towards the LGBTQ youth. And then of course you see in the third slide over, that's for Augusta Pride, which is happening this week. And they're actually a great community resource here. The last thing I want to stick away with you guys. So what can you do as an individual? Create clues or keep clues on you. You guys can probably see like the little transgender Mickey pin that I have. You saw my badge. My figs have like a little rainbow patch. I've gone a little bit overboard. But this all helps cue your patient into knowing that you're a friendly person to talk to. If your pen is rainbow colored, if there's a rainbow poster in your office, etc. Those are all very important. Really good clues that you guys can use. So I highly encourage you guys to do that. Updating your clinic. Like I said, with Family Medicine Clinic, we updated all of our forms so that they're more gender inclusive. We did trainings with people. We have gender neutral bathrooms, which in the South, you know, is a big deal. And then it's important to have LGBTQ brochures and posters that are not just AIDS brochures. So they're not just geared towards HIV. They're showing inclusive couples who have normal everyday health problems, okay? Here's my references, so you guys know I did the work. And that's it for me. So that was 58 minutes of LGBTQ medicine boot camp. I hope you guys learned something. If you have questions, hit me up. This is something I love this topic. So thank you for listening to me. And I hope you learned something.
Thanks so much, Søren. We do have a couple of questions that we wanted to ask you that came through from the audience. So the first one is, any advice that you have for students who might be interested in creating an LGBTQ plus medical practice?
Yeah. So for those of you down on the island, I actually started an LGBTQ club down there called the Glow Pirates that existed for an entire year. And then I left that island and no one continued it. So that's a good way to start it. But in terms of doing your own practice, because I've definitely thought about this. So you have to go into a specialty that allows you the flexibility for it. So shout out to family medicine. Family medicine's a choose your own adventure kind of practice. So is internal medicine. But really, you have to just start learning everything that you can, do a lot of the research on your own. There are several LGBTQ medicine fellowships. And by several, I mean like only like 5 spread throughout the US and mostly in major metropolitan areas like New York. I think UCLA has one. I think Northwestern has one. AU's talking about getting one and they wanted me to spearhead it, but I'm moving to San Francisco. So that's kind of what you have to do. You have to really just kind of immerse yourself into treating this population and just learning everything you can. There's a great article that came out from ACOG, the OBGYNs, the American College of OBGYN, I think. And they released it in March, I think, of 2021. And it's a 14-pager article about everything you ever wanted to know about transgender medicine. And I literally read that article every year, every 6 months, because it's so good. And it goes over the medicine, the culture, it goes over how to update your office, what to do if your patient becomes pregnant, the hormones, like everything. So you really have to kind of take it upon yourself to do it and practice it and volunteer at places like Equality Clinic. Next question.
Sorry. The next question was, have you ever faced any discrimination and how do you respond to that?
Yeah, so great question. Surprisingly, I have not as much. I think only like 1 or 2 or 3 incidences. And mostly it was like during the big presidential campaign of like 2018, right? I think because I present myself as such an authority on this topic, that tends to not get me discriminated against. And also it's how I present myself as a doctor, as I'm the authority on medicine in the room, getting you better. And so if you don't like me, tough, you might not have another doctor. And AU is really good about anti-discrimination policies. So if like you don't like your doctor, you're not going to get to doctor shop around until you find one that fits your prejudices. So you really have to play nice. And so usually when I do feel uncomfortable, I will definitely, like, you tell your attending, you tell your supervisor, you don't keep it inside and you don't take one for the team, right? But if you just kind of, I tend to be very nice and just outgoing and positive, and people don't, it's like kicking a baby seal, like people don't discriminate against that. But you have to be, it takes some confidence as well. You have to let people know that you're the authority on what you do. So tough. I hope that answered your question.
Perfect. And then we had one more, and that was, how can I urge my university to be more supportive of LGBTQ+ students, faculty, and staff?
Yeah. So usually there is some sort of gender inclusivity policy, and there's usually some sort of group that pioneers these efforts. So take a look, especially this month, because they should be doing something at your university. But I know like at AU, I think there's 2 main groups that do kind of LGBTQ inclusivity. And you just hit them up and you email them and say, hey, I'm going to be here. Like, can I volunteer or sit in on some meetings, stuff like that. And if you have absolutely nothing, then you might have to start something like I did at UMHS, or you just, you go to somebody who's involved in like programming and say, hey, can we partner and do something? Or can we partner with a community outreach resource and just kind of beef up like our LGBTQ inclusivity. But sometimes, you have to do a little bit of digging for it.
Perfect. And then actually one other question is advice that you might have for healthcare providers who have minors who are identifying as LGBTQ+, who may or may not have the support of their parents, and any considerations.
So that's an interesting question for these times. So my youngest patient is 4 years old and they are socially transitioned. They're not hormonally transitioned or anything. I have patients anywhere, like all the way up to the 18 and beyond, right? So with your minors, you just, if you see them for like a well child visit or something, that's the time where you check in on them, ask them open-ended questions about, do they have a boy? Well, that's not an open-ended question. Are they, in a relationship with anyone? Do they want to be in a relationship with anyone? Are they attracted to anyone? Stuff like that. And that kind of opens up that door a little bit. And then, like I said, like wearing the clues and stuff, because like they'll see that and they'll usually comment on it. And you can kind of pick up that like they, might be somewhere on this rainbow spectrum. And then you support them, you get them all the resources that they need. And then I know like in the state of Georgia, it was just passed that like we can't do hormone therapy as of July 1st coming up for anyone 16 to 17 and almost 18. So those minors. So then we have to just do like counseling and stuff. And so I do a lot of like consultations, and those patients will come to me and say, hey, I want to transition. when I'm allowed to, I say, great, here, read this. This is what you can expect. Come back in like 6 months if you want. We'll do like your well child visit and we can talk more about it so you know exactly what to expect when you start your transition. And then you come in the day of your 18th birthday and we will get you on your hormones. But yeah, oftentimes you need one parent or guardian to undergo HRT, depending on what state you're in. And so I guess like when in doubt, you can always ask the parents to step out of the room. I do that all the time. And then you just kind of ask like the point blank questions.
Perfect. Well, thank you so much, Søren. We really appreciate the wealth of information that you've shared. And I just want to let everybody know who's tuning in that this session is being recorded and will be posted to the UMHS YouTube page. So if you'd like to come back and revisit this information, share it with your colleagues and friends. The UMHS YouTube page is also a great resource for past discussions. We've talked about different primary care specialties. We've talked about cardiology, psychiatry. We've talked about women in medicine, working in rural areas. So just a lot of great information. It's an excellent resource for more information. But Søren, thank you so much. We really appreciate your time.
Anytime. Thank you for having me, guys. And you got this. I know it seems like you're a ways away from graduation, but you got this. You'll make it through.
Awesome. Thanks so much. And thanks so much, everyone, for tuning in tonight. We appreciate it.